3 weeks. It is acute in onset, low-grade fever, in intermittent type, with evening rise of temperature. It is associated with night sweats, not associated with chills or anger.
So it's a low grade fever and intermittent type. What is the significance of evening rise of temperature in this case?
Sir, evening rise of temperature is common in case of TB.
Okay. TB means?
Pulmonary tuberculosis, sir.
Yeah, you don't use short forms in your exam. Okay.
Okay.
So it's pulmonary tuberculosis. Then other differential diagnosis of fever and respiratory system with the evening rise of temperature.
Pneumonia.
Okay, very good. Then
Empyema, sir.
okay. Can it be a malignancy?
Lymphoma.
Yeah, that's what. Can it be a malignancy?
Yes, sir.
Okay, it could be a malignancy, but the onset of duration of fever is quite acute. You say that it's an acute onset of fever. So you have to explain more. In what time in the day fever is persisting? Is it in the morning or in the afternoon or in the evening?
Okay, sir.
You have not mentioned that, right?
Yes, sir.
So when the fever is predominant, is it in the early morning or in the evening? You have mentioned evening rise
Evening,
of
sir.
temperature, but in what time in a day the patient is having fever?
I missed that.
Okay. So can you name some fever with chills and rigor?
Malaria.
Malaria.
Urinary tract infection, sir.
Okay. What is the difference between chills and rigor?
Oh,
Sir, chills is shivering.
increased.
When does chills occur?
It increased vasodilation. There will be sweating, which causes swells, chills, and in rigor there will be uh, shivering due to vasoconstriction.
Okay. So what happens there, rigor? You want to create increase in your core body temperature or you want to decrease?
Decrease the core body temperature, sir.
Decrease. Rigor is a form of muscle contraction. Okay. The more and more you shiver, you want to increase your core body temperature. When you do exercise, what happens? Will your core body temperature increase or decrease?
Increases, sir.
Increase. So the same mechanism applies here also. During a rigor, the body muscles contracts so that the body temperature increases. Okay.
Okay, sir.
Yes, sir.
Understood?
Yes, sir.
So associated with night sweats you have written. When does night sweats occur and what is the importance of night sweats?
So due to increased cortisol production, there will be increase in
When
body
you say
temperature.
that the patient is having night sweat, it goes in favor of malignancy rather than your acute infective etiology. Night sweats indicates the patient is going for malignancy.
Yes.
Okay, so use night sweats cautiously. Okay.
Yes, sir.
Yeah. Next.
Breathlessness for the past 2 weeks, which is gradual in onset, progressive in nature, from grade 1 to grade 3, according to Modified Medical Research Council grading. Uh,
Hmm.
the breathlessness is relieved on lying left side. There is no history of orthopnea or no history of paroxysmal nocturnal dyspnea.
Okay. Can you grade a MMRC?
Yes, sir. There are 5 grades. Grade 0 is
Hmm.
breathlessness on strenuous exercise. Grade 1, there is shortness of breath when hurrying on the same level or walking up a slight hill. Grade 2, there is breathlessness while walking slower than people of the same age. Grade 3, there is shortness of breath while walking a few minutes or 100 yards. Grade 4, too breathless that the person even can't go out of the house.
Okay. So now he has proceeded from grade 1 to grade 3.
Yes, sir.
Okay. What is orthopnea?
Orthopnea is dyspnea on lying on supine position. It's relieved on
Lying on
sitting.
supine position. What is paroxysmal nocturnal dyspnea?
It is breathlessness that occurs in between sleep. The patient wakes up after 2 to 3 hours. Uh, he'll feel dizzy. He goes to near the window and gasps air.
What is the reason for or the pathophysiology of paroxysmal nocturnal dyspnea?
So there is an increased venous return, mm, which cannot be compensated by the heart. There is left ventricular failure. The
So
patient
in
will
left
feel
ventricular
dizzy.
failure, there is increase in the venous pressure. So there will be backflow to the lung vasculature where the dyspnea starts. Is there any correlation with PND and your case?
Mm, no, sir.
No. Okay, fine. Proceed.
Chest pain for the past 2 weeks, gradual in onset, progressive in nature, stabbing in thighs, was localized to the left side, aggravated on coughing and deep inspiration, relieved by lying on left side, was not radiating to the arms or jaw.
Okay. So why did you ask radiating pain to arms and jaw?
Uh, Sir, in case of
What are you going to interpret
angina,
with that history?
there will be radiating chest to rule out serious cause.
Okay. Now, in your case, the how do you want to explain the chest pain?
Mm, So it's a stabbing type of pain
Okay.
localized onto the left side. It increases with deep inspiration and coughing
So what
and
do you
gets
want to explain now?
relieved on
What type of chest pain is?
pleuritic chest pain.
Pleuritic chest pain. Okay. Proceed.
There is history of loss of appetite for past 2 weeks. No history of weight loss. No history of
What is
hemoptysis.
significant
No
weight
history
loss?
of
How do you define significant weight loss?
more than 5% of weight loss within 2 months.
Within
2 months.
3 months. 3 months.
3 months. Okay. Define hemoptysis.
Hemoptysis is defined as a expectoration of blood.
Okay. When do you call as massive hemoptysis?
Uh, when the blood loss is more than 500 ml per day, or
Is
when
that the
it's more
only
than 150
definition or?
ml.
Hmm,
No, sir. Or when it's more than 150 ml per hour uh, for more than 3 days.
okay. Okay. Proceed.
No history of wheezing, no history of hoarseness of voice, no history of dysphagia or halitosis, no history of pedal edema, right hypochondrial pain or abdominal distension, no history of any trauma to the chest.
So what is the significance of that pedal edema, right hypochondrial pain and abdominal distension in this case?
So to roll out core pulmonary,
Cor pulmonale.
So
right
the
heart
signs of
failure,
right heart failure.
right heart
Very good.
failure.
Signs of right heart failure. Okay. It could be any reason, this right heart failure. It could be impending left heart failure. It could be a cor pulmonale. It could be any valvular diseases. It could be a post myocardial infarction. Okay. There are empty number of reasons for right heart failure. What is the reason for
Okay.
halitosis?
In case of lung abscess,
Okay. Lung abscess. Any other condition you know? Halitosis.
So bronchiectasis.
Very good. Bronchitis. Any other system involvement of halitosis? Any
Poor
other
oral
system?
hygiene. Poor oral hygiene.
Okay.
Chronic liver disease, sir.
Very good. Very good. Chronic liver disease. History of weight loss.
in case of malignancy,
Malignancy then. In your case, if there is
tuberculosis,
also a history of weight loss, what do you want to suspect?
tuberculosis, sir.
Tuberculosis. Okay. Tuberculosis, malignancy. Then what is cachexia?
Muscle wasting along with weight loss, sir.
Okay. So in respiratory system and cachexia, not all the conditions causing cachexia and respiratory system.
In case of COPD, chronic
Very good.
obstructive pulmonary disease,
Okay. Pulmonary tuberculosis,
Bronchogenic
malignancy.
carcinoma.
Yeah, bronchogenic carcinoma. Okay. Proceed.
past history, no similar complaints in the past, not a non-case of TB, asthma, or chronic obstructive pulmonary disease. There is no history of diabetes mellitus, hypertension, or epilepsy. No history of recent tonsillectomy or tooth extraction.
Okay. Why did you ask for tonsillectomy and tooth extraction?
In case of any aspiration,
Aspiration. Okay. Where does aspiration occur? In which part of your lung?
Basal lobes, sir. Lower
Basal
lobes, sir.
lobe.
Lower
Lower
lobes.
lobe. Right side or left side?
Right side, sir.
right sir,
Hmm?
Right
right
lower
side sir,
lobes, sir.
Right or left? Which is the direct communication of your trachea and bronchus?
Right, sir.
Right. Where does bronchiectasis occur? Which part of your lung? Right side or left side?
Right side, sir.
Right side. Anyone else? Usual site for your aspiration will be on the right lung lower lobe. Okay. Especially when we say the segment, it will be in the apical and the posterior segment. Okay.
I didn't get you,
Bronchiectasis
sir.
usually occurs in the left lower lobe. Is it clear?
Bronchiectasis in left lower lobe, sir.
Yeah, bronchiectasis in the left lower lobe, whereas aspiration usually occurs in the right lower lobe.
Right lower lobe.
Okay.
Yes.
Yeah, so your case doesn't have any comorbids like diabetes, hypertension, nothing like that.
No, sir.
Okay. Now, what is the significance of diabetes and respiratory system? What are all the diseases you can get in uncontrolled diabetes?
Some more likely to get bacterial pneumonia, sir.
Very good. Then,
Atypical pneumonias.
okay. Diabetes and pneumonia. Which type of pneumonia you can get?
So,
Name two important bacteria you can see in diabetes patients,
Pseudomonas, sir.
especially with the cavity and consolidation. One thing will be Klebsiella pneumonia. The other
So,
thing will be
tuberculosis.
staphylococcus. Yeah, tuberculosis is always on the first.
Yes, sir.
Klebsiella pneumonia and Staphylococcus aureus are the two important organisms where you can see in diabetes patients, especially with cavitatory lesions. If you see any cavity and consolidation, first and foremost, tuberculosis. Second thing will be Staphylococcus aureus. Third thing will be Klebsiella pneumonia. Okay.
Yes, sir.
What is the significance of asthma or COPD in your case?
Asthma can have nocturnal cough.
Okay. How will be the COPD presentation?
Productive cough.
They can also have long-standing dry cough.
Yes, sir.
Usually bronchial asthma will have a early
Wheeze.
morning cough.
Early
Early
morning.
morning. Okay, proceed.
Family history. No history of similar complaints in the
Where is the
family.
personal
No
history?
history of any allergies, asthma, personal history. Next slide, sir.
Past history, then personal history. Then only you have to go for family history, all other things.
Personal
Okay, you
history.
finish
Patient
personal history
consumes
now.
patient consumes mixed diet. Is not a smoker, alcoholic, or a tobacco chewer. There is no known allergies. Bowel and bladder habits normal. Family
What is smoke
history. No
index?
history. Yes, sir.
Smoke index. You asked for history of smoking, right?
It's number of cigarettes smoked per day.
Smoke index, huh? What is pack year then? Pack year.
Number of cigarettes per day divided by number of cigarettes in a pack into the number of years you smoked, sir.
Okay. Then what is smoke index? Hello.
Sir, it is the same, sir.
No, no, both are different.
Okay.
You, you have Hutchinson textbook.
Yes, sir.
You go back and read today. What is pack here? What is smoke index? Both are different.
Yes, sir.
Yes, sir.
So he's not a smoker, not an alcoholic. So he doesn't have any risk factor.
Yes, sir.
Okay, then proceed.
Family history. There is no history of similar complaints in the family. No history of any allergies, asthma, respiratory tract infections in the family. No history of smoking among family members. Contact history. No history of
The second
contact
thing
with
is
the known case of.
respiratory system. Respiratory system, you have to mention about the housing also. Is it a paka house or a kacha house? Okay. Is there any indoor pollution? And how many members of the family are inside the house? Okay. All these things can say few words about communicable diseases inside the house, and also the socio-economic status to be mentioned.
Yes, sir.
Okay. Then contact history. Okay, fine. Proceed. Next.
Treatment history. There is no significant treatment history.
What a significant history you asked for treatment?
Sir, if you have any prior respiratory tract infections or any treatment for tuberculosis.
Any name some drugs causing cough?
ACE inhibitors, sir.
Enema? ACE inhibitors.
AC
Then
Yes.
any other drugs? Okay. Proceed. It's a very important question. Drugs causing cough. Drugs causing pleural effusion. Okay.
Okay, sir. Summary. A 53-year-old male, Mr. Sharan, came with the complaints of cough and fever for 3 weeks, followed by grade 3 dyspnea and chest pain for 2 weeks. The probable system involved is respiratory system.
Okay. You can say the uh, probable diagnosis also. Cough, fever, and breathlessness for the past 3 weeks. So, what do you want to comment on your diagnosis? Inside the respiratory system, which part of the lung could be disease involving?
Pleural involvement, sir.
Is it a parenchymal or a pleural or an airway?
Pleural involvement, sir.
Pleural involvement. So you want to confirm your diagnosis with examination. Okay,
National
that's it you have to
respiratory
say.
system.
Yeah, proceed.
General examination. Patient is conscious, cooperative, oriented to time, place, and person. He is dyspneic and tachypneic, moderately
Can
built
you
and
comment
moderately
on
nourished.
consciousness and respiratory system? Name few
Sir, in
conditions
case
where
of
consciousness is lost with respiratory
sir, in
system.
case of uh, tuberculosis meningitis, there will be olfactory.
Okay. Common things. Common things.
So carbon monoxide poisoning, they would be
Common.
unconscious.
Common. Carbon monoxide and all not that much common. Tell me about common things first.
Pneumonia, meningitis due to pneumonia.
Yeah, pneumonia. Pneumonia with respiratory failure. Yeah, proceed, ma.
Grade 1 clubbing is present. There is no pallor, expressed cyanosis, pitting pedal edema, or no generalized lymphadenopathy.
What is generalized lymphadenopathy? What is generalized
There is
lymphadenopathy?
lymph node enlargement of more than 2 nodes in non-contagious groups.
What is significant lymphadenopathy?
And there is when the size of lymph node in the supraclavicular region is more than 0.5 centimeter. In the axilla, the size of the node is more than sorry, sir. In axilla, if the size of node is more than 0.5 centimeter. In clavicle, it's more than 0.1 centimeter. In the inguinal nodes, if it's more than 2 centimeter.
Okay, proceed. Patient is tachypnic and dyspneic.
Yes, sir.
Okay, what is the respiratory rate?
28 per minute.
28. What type of respiration is that?
Abdominothoracic type.
Abdominothoracic. What is normal type of respiration in a male and a female?
In the male, it's abdominothoracic type, and in female, it's thoracic abdomen.
What are all the accessory muscles you looked for respiration?
Laryngovela nasi, uh, scalene, trapezius, and sternocleidomastoid muscle.
Okay. Temperature is 100. Okay. Pulse okay. BP okay. JVP not elevated. So when will be JVP elevated in case of respiratory system?
So in case of right heart failure, pulmonary hypertension causing cough, and
Okay. Okay, fine. Next.
examination of the respiratory system, upper respiratory tract examination, nasal contour normal, no deviated nasal septum, no nasal polyps, no sinus tenderness, oral cavity examination, there is no staining of teeth or dental caries, no halitosis, no tonsillar enlargement, no postnatal drift, posterior pharyngeal mound.
Okay.
On inspection, the chest wall appears to be symmetrical, trachea appears shifted to the right side, typical impulse not visualized, there is fullness of intercostal space on left side, chest wall movements appears to be decreased on the left side, accessory muscles are active, no hollowing of supraclavicular or infraclavicular space, no abnormal pulsations, visible scars or sinuses seen, there is no kyphosis or scoliosis.
Okay. Now you say that the chest wall is decreased on the left side, right? How can you comment that chest wall is symmetrical?
So, yeah,
The chest wall movement is
nothing.
decreased on the left side.
Yes, sir. On palpation, uh, we have to measure the chest circumference during inspiration and
No.
expiration.
We are talking about inspection. In inspection, you say that the chest wall is symmetrical,
Yes, sir.
correct?
Yes, sir.
Now on the fifth line, you say that the chest wall movement appears to be decreased on the left side.
Yes, sir.
Both are not matching, right? Symmetrical, you are saying in the first line. Fifth line, you say that the chest wall movement appears to be decreased. If chest wall movement is decreased on the left side, how can you comment that the chest wall is symmetrical?
So there is no chest deformity seen.
Can you repeat?
No chest deformities are seen.
No, it's not audible.
Hello, sir. So there is no chest deformalities.
Yeah, there is no chest deformity. Okay, your answer should be that. Since there
Okay,
is no
sir.
chest deformity, I say that the chest wall appears to be symmetrical. Okay, continue.
Palpation. Trachea confirmed to be shifted to the right side. Apex seat not palpable. Chest movements reduced on the left side. Chest expansion 2 centimeter. Hemithorax expansion reduced on the left side. It's 1.5 centimeter on right side and zero point 0.5 centimeter on left side. Chest measurements: anteroposterior diameter 20 centimeter, transverse diameter 28 centimeter. There is no chest wall tenderness. Vocal fremitus absent in the left mammary, axillary, intra-axillary, interscapular, and infrascapular areas. And it is normal in all other areas of left side and right side.
Okay, what is trail sign? TRAIL, trail sign.
It is the prominence of the clavicular head of sternal femur maxilla towards the pediatric side of the.
Okay, how did you measure the chest expansion?
So with the in-state uh, aspiration to inspire and then take a deep inspiration and take the chest wall circumference, then measure the circumference during expiration also.
Okay, proceed.
On percussion, all areas of right side were normal. There is a stony dull note in the left side infraclavicular, mammary, inframammary, axillary and infraaxillary, infrascapular and interscapular areas. Frog space dull to percussion.
Okay, now what are the different types of resonance in respiratory system?
There is normal lung is resonant. It is decreased resonance in case of fibrosis and consolidation, hyperresonant in case of pneumothorax, stony dull note in case of pleural effusion.
Okay, how many areas are there in your lung?
Sorry, sir. Hello, sir.
Sorry, ma. What is it? Inframammary.
Sir, I did
You've written that
inframammary.
inframammary, no?
Yes, sir.
From where did you get inframammary? Which book says inframammary? That is why I asked the question, how many areas of percussion are there in lung? Can you tell the reference? From where did you take this?
Sir, Alagappan.
Alagappan. Which edition of Alagappan? Did you check standard textbook?
Edition.
Hutchinson. McLeod and Hutchinson you refer, ma? There are
Yes.
only 8 areas of percussion now. Okay. Inframammary has been taken. Okay. Supraclavicular, infraclavicular, mammary, axillary, infraaxillary, suprascapular, infrascapular, interscapular. That inframammary has been taken out. Okay. Just refer your standard textbook.
Okay.
All right.
Okay, sir.
Next. Proceed.
On auscultation, normal vesicular breath sounds are heard in all areas of right side. On the left side, diminished breath sounds are heard in the infraclavicular, mammary, axillary, infraaxillary, interscapular, and infrascapular areas. Vocal resonance absent in the left clavicular, mammary, axillary, infraaxillary, interscapular, and infrascapular areas. Normal in the left supraclavicular and suprascapular areas. Vocal resonance is normal in all areas of the right side. There are no added sounds.
Okay. What is tidal percussion?
So it's trying to divide diagonal from the pleural pathology on left side.
Yeah, proceed, ma. Proceed.
The tidal percussion is done to differentiate liver dullness from pleural disorders.
No, no. When do you want to do tidal percussion?
So in case of any liver enlargement or
Okay. Is it due to liver enlargement or right-sided pleural effusion? What you are going to find out after doing this tidal percussion?
to rule out whether the dullness is due to right-sided pleural effusion or the liver disorder.
Okay. Proceed.
Other system examination: CVS S1 S2 normal, no murmurs, abdomen soft, non-tender, no organomegaly, CNS no focal neurological deficit.
Okay. Okay. Next. Proceed.
Diagnosis: a case of left-sided pleural effusion, probable etiology being tuberculosis, with no signs of congestive cardiac failure.
And the patient is not having respiratory failure. You have to add that also.
Yes.
Okay. What is CB NAT?
Cartridge-based nucleic acid amplification test.
What is the duration of test procedure? When will you get the result? How long it will take?
Within 2 hours, we'll get this.
Yeah, within 2 hours you will get. What are all the different sample you want to do for CB NAT?
So sputum
Okay.
for pulmonary,
Now
sir.
in
Yeah.
your case, it's a pleural effusion. So are you
So,
going to do pleural aspirate
yes,
and
sir.
send for CB NAT, or you want to do anything else? Any other special investigation you want to do, which is more specific and sensitive?
Pleural biopsy, sir.
Yeah, pleural biopsy is more sensitivity and specificity. In pleural fluid analysis, what is the specific test you want to rule out for tuberculosis? Is there any specific test you want to do?
The nature of the fluid, whether it's translate or exudate.
Sorry, ma, I couldn't hear you.
The nature of the fluid, whether it's translate or exudate.
Okay. No, any other specific biochemistry test you want to do? What is the ADA?
Yes, sir.
Adenosine deaminase.
ADA is elevated in case of tuberculosis.
Yeah, you have to do specifically for ADA, adenosine deaminase levels. Okay.
Yes. Yes, sir.
You've written laryngeal swab or laryngeal lavage for tuberculosis. What is that?
Sir, if the cough is non-productive, sir, so to
No, where are they doing this laryngeal swab for tuberculosis? I have never heard about these things. Laryngeal swab or lavage. From where did you take this laryngeal swab or lavage? Which textbook says? Presenter.
Sir, I took the case. Senior.
From where did you take this reference?
Sir, reference was from another
I
friend.
couldn't hear you, ma.
Hello, sir.
Yeah, tell me.
Reference was from another friend.
Laryngeal swab or lavage. Don't comment about these things in your exam. Okay? Laryngeal swab,
Yes, sir.
lavage, these
Yes,
things
sir, I'll delete
should
that.
not be examined. Yeah.
I will delete that, sir.
Yeah. Next, proceed.
Treatment therapeutic pleural tapping and for tuberculosis and the tuberculosis.
Yeah, ATT. Can you categorize ATT? How many categories are there?
so first line, second line,
How many categories are there?
uh, drug sensitive TB and drug resistant TB, sir.
Resistant TB. Uh, in drug sensitive TB, how many categories are there? 1, 2, 3. How many categories?
So now there are no categories like that, sir. New and
They are
previously
taken.
treated.
Hmm.
New and
Board
previous.
examiners will ask
Okay.
how many categories are there.
So, I guess category 1 is new patients, sir. Category 2 previously treated, sir.
Previously treated, defaulter, and relapse.
Okay.
Okay. What are all the first line drugs you know?
Isoniazid,
Rifampicin, isoniazid, ethambutol, and pyroxene.
And this which is bacteriostatic drug and bactericidal drug.
rifampicin and isoniazid are bactericidal, sir, and pyrazinamide and ethambutol are bacteriostatic, sir.
Is it? Today you go back and read WHO ATT drugs. Okay, very important for your exam. Right. Name some criteria for pleural fluid tapping. What is that light criteria?
Uh, on light of ratio of pleural fluid protein to serum protein more than 0.5, ratio of pleural fluid LDH, serum LDH more than 0.6, and pleural fluid LDH more than upper limit of normal serum LDH. If any of these three criteria is positive in the oxidative effusion, all the three are not, which is fine.
Any other criteria name you know for pleural disease?
SFAD, serum fluid albumin gradient.
Serum
If
fluid
it's more than
albumin gradient.
1.2, It's more than
There is
1.2
something called as
gram per
Hefner's
deciliter.
criteria. Have you heard of Hefner criteria? Heffner, Hefner criteria.
No, sir.
Okay, you go back and read what is Hefner criteria. And there is something called as
Yes.
extended light criteria.
Okay, sir.
Okay. Light criteria is different. Extended light criteria is little different.
Okay, sir.
Okay.
Yes,
So
sir.
you read all these things and you have to know what is the difference between an exudative and a transudative pleural type of effusion and few causes of transudate effusion and exudate effusion.
Yes, sir.
Okay. All these things can be asked in your exam. Okay. Otherwise your presentation is excellent, but only thing is that inframammary should not be used. Okay.
Okay, sir.
Fine.
Thank you, sir.
Any other doubts? Yeah. Any other doubts you have?
Sir, amiodarone can cause pleural effusion, sir.
Yeah, it can cause pleural effusion. Methotrexate, amiodarone, both these drugs can cause.
Okay. Sir, and methotrexate is used commonly these days, sir.
Not commonly used, quite
Okay.
very rarely used. But when they ask you this type of question, you have to answer.
Okay, sir.
It's very standard question. Name 3 drugs causing pleural effusion. Very commonly asked.
Yes, sir.
Anything else? Anyone else you want to ask any doubts? Then we'll wind up. Okay.
Thank you,
Thank you,
sir.
sir.